In Unit 14, we will discuss hemotherapy and organ transplantation. Indications for transfusion for any component must be defined. The Circular of Information is a guidebook for physicians, and a copy is found in the reference section for this unit. Transfuse the appropriate product for the patient's condition. For example, if the patient is anemic, they do not need whole blood. They only need the packed cells. The 4 products most frequently used for transfusion are red blood cells, apheresis platelets, fresh frozen plasma, and cryoprecipitate. Some additional transfusion considerations are for those patients who require irradiated blood products and CMV negative blood products. For red blood cell transfusion, it's used to treat symptomatic anemia. So the patient has come in, they have a very low hemoglobin, they are short of breath, they have pallor, they're weak, no energy. Then the test results along with the patient's symptoms would possibly indicate transfusion. On the other hand, for sickle cell patients, the doctors are very happy with a 6 to 7 hemoglobin. And we don't want to transfuse them any more than necessary because they generally are the most serologically complex patient that you'll ever meet. I had one sickle cell patient that had 7 allo antibodies. I was able to identify 6, and we sent it to a reference lab, and they identified a 7th. Finding blood for that patient is a nightmare, and every time you transfuse them, they have the ability to make an additional allo antibody. So again, don't treat unless the anemia is symptomatic. What is the criteria for selection? ABO compatible. So this is for red cells, which is the universal donor, group O. It must be negative for antigens that patients have clinically significant allo antibodies to. And this is why it is so important that you correctly identify allo antibodies. Once you identify, for example, an anti-Big E in that patient's serum, for the rest of their life, they must get Big E negative blood, which adds a lot to the price of that transfusion. For infants, it must be compatible with both the baby and the mother and lack antigens to which the mother has clinically significant antibodies. And this is why the cross-match, especially with the mother, is so important because that will identify whether or not you have missed an antibody. And with the baby as well, just to verify that it will be compatible with the infant as well. Current thinking is to transfuse the minimum amount of blood needed by the patient, which may be 1 unit. I used to say, if you need 1 unit of blood, you don't need blood. But now they're really strengthening the criteria which must be met for transfusion, and that criteria may indicate only 1 unit of blood. What are some patients' conditions that would indicate the transfusion of red cells? Oncology patients. Oncology patients are given chemotherapy. Chemotherapy targets fast-growing tissues, and that would include the bone marrow. It's an innocent bystander that gets destroyed. So when patients are undergoing chemotherapy, they will be transfused quite a bit. Trauma victims who are bleeding out. Cardiac, orthopedic, and other selected surgeries. There's a list of surgeries that are typed in screen protocols because we can get the blood out within minutes when needed. And there's a list of surgeries that the patient will bleed and will need blood, which we will cross-match. End-stage renal disease. Where is the hormone that stimulates red cell production produced? In the kidneys. So when the kidneys fail, we don't have that stimulation, and these patients will require transfusion. Diseases such as sickle cell, thalassemia, aplastic anemia. Additional considerations for transfusion of red blood cells is if the patient is immunosuppressed, give CMV negative blood. If there's a risk of transfusion-associated graft versus host disease, give irradiated blood. Apheresis platelets, they're collected by apheresis from a single donor. So a unit of blood is removed, it's spun down, the platelet-rich plasma is removed, and the red cells are returned to the donor, and they do this through several cycles. It's used to treat thrombocytopenia, and to understand the function of platelets, you need to bring coag back to the front of your brain. I know you don't want to do it, but you gotta, because a lot of what we do in the transfusion service is related to products to correct coagulation deficiencies. So the platelets, the function is maintenance of vascular integrity, initial arrest of bleeding by platelet plug formation, and for many types of little bitty wounds, this is sufficient. For larger wounds, stabilization of the hemostatic plug through contribution to fibrin formation. Criteria for selection, ABO compatible if at all possible. For infants, we definitely want ABO compatible. They generally make AO and AB platelets, which is the universal donor for plasma, AB. And this product is 98% plasma, and then we have platelets, and then we have some contaminating red cells. If ABO compatible is not available, limit exposure to ABO incompatible platelets. For example, we used to give 2 Group O apheresis platelets to a non-Group O, but once we exceeded that limit within a certain time period, we would wait for ABO compatible, because our concern was the quantity of ABO antibodies present could cause hemolysis. You want to give D negative for D negative recipients. If you must transfuse D positive platelets, because if you ever have an opportunity to see one of these platelet units, take it off the rocker and allow it to settle, there are red cells in there. Usually it's minimal, but there's still enough that they could sensitize a D negative person. So in those cases, we have a formula to use to give Rh immune globulin. What is Rh immune globulin? It's anti-D in a bottle. So we'll calculate the dose and then give that to the patient. What are indications for use? Again, chemotherapy or radiation therapy, because it will affect the bone marrow. Post-hematopoietic progenitor cell transplant recipients. This is when we replace the patient's bone marrow with these progenitor cells to treat many different diseases. And during the process of destroying their bone marrow, they need to have support, component support for all the components. Peri or post-operative bleeding, thrombocytopenic purpura, and thrombocytopenia due to other causes. Additional considerations: if they're immunosuppressed, give CMV negative, and if there's a risk of transfusion-associated graft versus host disease, give irradiated. 1 unit of apheresis platelets is considered a therapeutic dose. Back in the day, and even sometimes during modern days, we make a random platelet from a donor unit. And how we do this is we spin the blood down, we harvest the platelet-rich plasma, we spin that down, we take off most of the plasma except maybe 50 cc's, and then we have a single random donor platelet. But that's not a therapeutic dose except for a baby. So in order to be a therapeutic dose, we pool the 6 random units into 1 bag. Fresh frozen plasma, it's used to replace clotting factors, including the labile factors 5 and 8. And plasma must be frozen within a certain time period after collection to be called fresh frozen plasma. Criteria for selection must be ABO compatible, because it's all plasma and there's ABO antibodies. Cross-matching is not necessary. For ABO selection, think of ABO antibodies in the patient. AB is the universal donor for plasma products. Group O is the universal recipient for red cells. So why is Group AB the universal donor for plasma? Well, that's because for red cells, for a universal donor, we look for a cell lacking all ABO antigens. In plasma, we're looking for plasma that lacks all ABO antibodies. And group AB people are the only ones that do not have anti-A and do not have anti-B. Blood bank requires you to think a lot, and that's why I love it. Preparation of fresh frozen plasma for transfusion. You never thaw until the order is given, is confirmed. When I was new in the transfusion service, I would receive an order for 2 units of FFP, and I'd begin to thaw them. And then when I called to tell them they were ready, they said, "Oh, we just put in the order. We're not ready yet." I was like, "Oh, man." So I always, when I got the order, I confirmed whether it was for now or later. To thaw it out, it has to be thawed at 37 degrees for 30 to 45 minutes, and there's several methods available, which we already talked about. You must use protective overwraps to protect the ports from contamination, because we use this same bath over and over and over. The expiration is 24 hours. After 24 hours, it can be relabeled thawed plasma and used for 5 additional days if it's not needed for factor 5 or 8. What are the indications for use of fresh frozen plasma? When clotting factor concentrates are not available, during a massive transfusion because the patient's losing everything, and so they need red cells, they need plasma, they need platelets, the whole kitchen sink. Patients on warfarin who are bleeding, plasmapheresis, where for whatever reason they need to remove the patient's plasma and they'll replace it with donor plasma. Severe liver disease, disseminated intravascular coagulation, and rare specific plasma protein deficiencies. 2 units are frequently ordered for a therapeutic dose. And again, verify that the transfusion is needed now before you thaw them out. The next product we will discuss is cryoprecipitate. So what is it? If you recall, when we were talking about the donors and the component preparation, this is an insoluble precipitate which forms when FFP is thawed at 1 to 6 degrees centigrade. That's in the refrigerator. It was discovered that this contains high levels of concentrated factor 8 and fibrinogen. The volume of each unit, because they will spin it down, harvest the plasma off of it, and then that's labeled plasma cryo removed, and then what's left is about 10 to 15 mLs of this precipitate. The criteria for selection: due to the small volume, the ABO group does not matter unless the patient is an infant or a small child. ABO compatibility considerations are the same as FFP. Preparation, again, never thaw until the order to give is confirmed. And again, this must be thawed at 37 degrees, rapid to protect the ports. And for adult patients, pool 6 to 10 units for a therapeutic dose. So on the right-hand side, you can see a picture that illustrates how we, using aseptic technique, we have a transfer bag, and we will insert into the port and drain the unit of cryo into the transfer bag. Then we'll remove the device from the empty bag and put it on another bag. And so we'll do this repeatedly, again, being careful not to touch the device against any surface or with your fingers to where it's not contaminated. The expiration when it's frozen is 1 year. Once you thaw it, it's 6 hours. And once you pool it, due to the risk of contamination, it needs to be transfused within 4 hours. So we never pool it until we get the order to give. What are the most common indications for use? Fibrinogenemia, massive transfusion, disseminated intravascular coagulation, and von Willebrand's disease. Massive transfusion protocol: a massively bleeding patient needs everything. Massive transfusion protocols have been studied and are proven to reduce mortality rates. The numbers will vary according to the institution, but standardizes the protocol to transfuse components. One of the most common examples are 6 units of red cells, 4 units of FFP, and 1 unit of apheresis platelets. And I recall situations in which there was a massively bleeding patient in the OR, and I would call and say, do you think you're ready for some platelets now? Do you think you're ready for some cryo now? Because they're so in the moment to save this patient's life that they're not thinking of components. And so the doctor said, oh, yeah, let's have, so they put the orders in. So sometimes you have to step in and just offer suggestions, not tell them what to do, but offer suggestions as to when maybe is a good time to transfuse some additional components. So this massive transfusion protocol will continue until the lab results are within normal limits. We'll now move on to transplantation, and they're defined by the type of tissue. So we have solid organs, kidney, liver, lungs, intestine, pancreas, heart. Living donor tissue and cell allografts. For example, hematopoietic progenitor cells. This can be either bone marrow or peripheral blood used to transfuse or replace the bone marrow of the patient. And cord blood. Tissue allograft, this is bone, heart valves, tendons. It's human tissue, but just pieces of it. Transplantation requirements for solid organ compatibility testing. The organ must be ABO compatible for solid organ transplants, and it must be HLA compatible, which we'll talk about in a minute. We had an individual come apply for a job at our transfusion service, and just a little background, we had heard that in West Texas a patient had died after a heart transplant because the heart was mistyped. And so when this person came in to interview, when he said which hospital he's from, we said, oh, that's where the heart transplant patient was mistyped. And he said, my lawyer has told me not to talk about that. So we knew that was him, and he did not get the job. Which, we're all human and we all make mistakes, but to make a mistake that costs another individual their life, this is when you kind of get into the ethics and morals, and it's just a real difficult thing to call when you made this mistake. Should you be punished for the rest of your life, or did you learn your lesson? I personally would never work in a transfusion service again. I would find a job in a different department. Progenitor cells or bone marrow, ABO doesn't matter. The reason ABO doesn't matter is their bone marrow will be totally destroyed prior to giving them these progenitor cells, which will find their way to the bone marrow and replenish. They must be HLA compatible. For other tissues, bone, etc., they're only stored. No compatibility testing is necessary, and bone and corneas are the most common. We used to have them in the transfusion service, and it was so annoying that they had different size bones that they would use depending upon the surgery to rebuild. For example, somebody's jaw was shattered. They would use this cadaver bone to help reshape and get that back in order. So again, we do nothing with it except we have it in our system, and we get an order and we give it out. So we just store it. The transfusion service role is accurate ABO typing of the potential donor and supply blood and appropriate blood components to the patient. So we're going to bring immunology back to the front of your brain. Human leukocyte antigens, we talked about those, and you may want to review that section in your textbook as well. HLA is a complex array of genes and their molecular products involved in immune regulation and cellular differentiation. HLA antigens are found on the surface membranes of all nucleated cells. So are you going to find HLA antigens on red cells? No, because they do not have a nucleus. The HLA antigens are second in importance to only ABO for solid organ transplant survival. So ABO and HLA typing must be done. HLA antigens are found on the surface of nucleated cells, which includes white blood cells. The function of HLA is to help identify and in turn fight foreign stuff. So they're part of your immune system. There's two types of HLA, some for the MHC1 and MHC2. MHC genes are on chromosome 6. The most important HLA antigens are types A, B on the MHC1, and DR on the MHC2. MHC1 presents antigens to cytotoxic cells, and MHC2 uses antigen-presenting cells for helper T cells. For this reason, it's important to have closely matched HLA between the donor and the recipient to avoid rejection. And this means to avoid donor cells being presented to the recipient's immune system by the MHC for destruction. Because once they start forming these tissue antigen antibodies, these antibodies will then attack that donated tissue. For the first weeks and months after the transplant, the patient is carefully monitored for rejection. Recipient qualifications for an organ transplant. The list of individuals waiting for organs far exceeds the supply to this day. In most cases, they won't accept individuals who are over 60 years old. Other disqualifications include recent myocardial infarction, which is a heart attack, an active infection, malignancy, substance abuse, or limited life expectancy from an unrelated disease. The information on this slide is for your information. Once harvested, the organs must be transplanted quickly. And yes, they do put them in regular igloo coolers packed with appropriate cooling materials to transport it to the hospital where the transplant will be done. Kidneys are good for 48 hours, and the donors can be living or deceased. And an interesting thing about the living donors, there's one hospital, and it made the national news, that they found donors that, okay, I need a kidney transplant, and they found somebody who needed a kidney who was compatible with their spouse or a friend. So that these people arrived, and they all had to arrive on the same day, same time, and all the procedures were done at the same time. Because what if I said, okay, I have this person who's going to give you their kidney, so I got your kidney and my person backed out. So to prevent that from happening in living donor situations, this is not uncommon that they have all the people at the same place, same time. Pancreas is good for 24 hours. A liver is only good for 12 hours, and it can be living or deceased. You can live with a tiny piece of your liver, but once that goes, you're done. And vice versa, somebody, and usually it's, people who are related, but they give a piece of their liver to someone else who needs it, and that liver will regenerate to full size. Kind of interesting. Corneas for your eyes, 8 hours. Hearts and lungs, 6 hours. The recipients closest to the location of the donor and who match are the first ones offered the organ. So they'll have, now we use cell phones, that they will be contacted when an organ becomes available, and they must immediately respond because we don't want organs to expire. For example, maybe this organ came from New York City, and the travel time has decreased the amount of time for us to do the transplant. If you have an opportunity and you're curious, visit the United Network for Organ Sharing, UNOS, and it's the clearinghouse for organs. So anybody who has an organ available for transplant submits the information to UNOS, and then they will find the appropriate person who's at the top of the list for that organ. Transfusion support. Liver transplants require the most blood components. The problem is if the patient has alloantibodies, and I've talked about this before. So we know they're going to massively bleed. So if they have an alloantibody, we'll use antigen negative for about maybe the first 5 to 10 units because we don't want to cause an acute hemolytic transfusion reaction. So once we've given those units, you switch to unscreened or partially matched units. For example, go ahead and hopefully we have a lot of patient sample. Use the patient sample to screen 10 or 20 donors and see if we can find donors that are Coombs cross-match compatible, but they're not phenotyped. Then you want to save 5 to 10 units of antigen negative blood for the end so that we fill them up with antigen negative blood. This requires really close communication between the physician and the transfusion service. You may use pre-op plasmapheresis to reduce the titer of clinically significant antibodies if they're giving a very high reaction. So do a titer on the patient. If it exceeds a certain amount, what you'll do is, again, the patient's hooked up to a machine and we take a unit, spin it down, discard the plasma, and then we return the red cells along with regular donor plasma that does not have any antibodies. So again, this is used to decrease the amount of clinically significant alloantibodies. Massive transfusion paralyzes the immune system due to antigen overload, and it will take time for the immune system to get back up and running to full capacity. So this patient has had a transplant. They're going to put them on heavy-duty immunosuppressive drugs to basically shut down the immune system. So those incompatible cells that remain are probably safe because we've thoroughly emptied the patient of blood, replaced it totally with donor blood, and so by the time the immune system wakes up, then, and again, because they're on immunosuppressive drugs, this really shouldn't be an issue. Transfusion support for other types of transplants is usually not a problem. They are not bloody surgeries. Solid organs must be ABO compatible except for bone marrow transplants, which we'll talk about in a minute. Follow the transfusion protocols at your institution, and products must be irradiated and CMV negative. Marrow transplantation, there are 4 different types. There's resources for getting bone marrow or the cells necessary to regenerate a bone marrow. There's the autologous hematopoietic progenitor cells. These are called HBC. It's not really a transplant, but a rescue. While a patient is in remission, they will collect the hematopoietic progenitor cells and freeze that blood. Remember, frozen blood is good for 10 years, and it can only be used for that patient. Allogeneic hematopoietic progenitor cells, so we'll find somebody who is HLA compatible and harvest their progenitor cells. And this is done by giving them medications that cause increased release of these progenitor cells from the bone marrow, and they take the blood out just like a regular donor, and it has special filters to filter out the progenitor cells. Actual bone marrow from a living donor, this is not done as much anymore because the progenitor cells have basically replaced this. But there may be occasion that a donor will have to undergo general anesthesia, and then they take the bone marrow from their bones. And cord cells. This led to harvesting and freezing of cord blood after birth. The fear, unfortunately, manufacturers, they find the buttons to push for people to buy their products, and in this case, it's your child's health and safety. What if your child was to get leukemia later on in life? Well, these cells would be available so that they could have an auto transfusion of progenitor cells because there's a high level of progenitor cells in cord blood. Progenitor cells are those cells that don't know what they're going to be when they grow up. The purpose is to reconstitute or rescue the patient's hematopoietic system after destruction of the recipient's bone marrow. The procedure, you totally destroy the patient's bone marrow. The patient must be in reverse isolation. They spend months in the hospital. So everything that comes in their room must be sterile. They'll usually have a plastic curtain around them to where if they have to touch the patient, it's done through these plastic gloves built into these curtains. Then after the bone marrow is destroyed, they infuse the HLA-matched HPC, allo, or auto, or bone marrow, or cord cells, whatever product has been harvested for this patient. And they do it just like a blood transfusion. It's amazing. They have a bag, they apply an IV needle, and then it's infused into the circulatory system. And they know where to go. They go to the bone marrow. I still find that amazing. And then the patient is monitored for engraftment. What are some indications for bone marrow transplantation? Hematologic malignancies are number one. Leukemias, other types of cancer of the blood. Severe immunodeficiency, to where they can replace the deficient bone marrow with bone marrow that will be immunologically competent. Aplastic anemia, a condition in which the patient just quit making red cells, or any kind of cells. And hemoglobinopathies, sickle cell disease. Until we can have a gene therapy for it, what they do is they take somebody who does not have sickle cell and they destroy and replace the sickle cell bone marrow with normal. And so this will cure the patient. Malignant diseases are the most common indication. The success rate depends on the patient's disease and the stage of the disease, the degree of prior treatment, the age and condition of the patient, and the degree of HLA match between the patient and the donor. Transfusion support. The transfusion service must carefully follow protocols and determine the phase the patient is in. In phase 1, this is right after the transplant's been done, ABO compatible with the recipient, because there's still a lot of blood in the patient. Phase 2, ABO compatible with the recipient and the donor, which usually means giving group O blood. And then phase 3 is ABO compatible with the donor, because theoretically most of the patient's red blood cells are gone. So if there are a few left, that's okay, because the new bone marrow will make antibodies against those cells and they will be taken out of circulation. Bone marrow transplants can cross ABO lines. For example, a group O recipient can be given group A donors. The patients are put on heavy-duty immunosuppressive drugs to decrease the amount of antibody production. The ABO incompatible transplant makes it very easy to track success through ABO typing. As engraftment of the donated bone marrow occurs, we will see a transition from group O to group A, which indicates success. So you do your typing, and remember the patient's group A. So you may see 3+ with the anti-8, because there's still a lot of patient cells present. As the progression goes on, you'll get a 2+. Then as the progression goes on and it's successful, you'll get a 1+. And eventually the patient will type as group O. That indicates 100% success of engraftment of this bone marrow. This is why it is so important that you always check patient records first in any situation to identify this situation. And we saw several while I was working in the transfusion service. In fact, it didn't surprise us. We would get a person who previously typed as group A and now they're group O. Well, the first thing we want to do is make sure the wrong patient wasn't collected. So we get a recollection first, because perhaps the transplant was not done at your facility. Well, if it still types the same, then we'll have the nurse question the patient, have you received a bone marrow transplant? And sure enough, this patient had. And it was, I don't know, kind of amazing to see this happen in real life. And it doesn't hurt to repeat the information from the previous slide. The challenges for the transfusion service after successful transplant with ABO marrow that's different than the original ABO type is during transition, mixed field results and ABO discrepancies will occur. And the good news is this indicates a successful engraftment. The historical type will be one type, the current sample will be another type after successful engraftment. History is crucial in these situations. You must have the patient redrawn to verify no collection error occurred, and then, after that's verified that there was no collection error, you must document from medical records when the transplant was performed. So I want to get which hospital, what date, because those are very important in verifying the information. Here are some additional references in case you're interested. This is the end of Unit 14. Please share your questions with your instructor to get additional clarification.